Good afternoon. I'm Ellen Hahn. I'm the director of UK Cares. I recognize several of you, several new names. Awesome. We are so excited today to host our July Environmental Health Seminar. If you don't know about UK Cares, please visit our website. We got lots of services. We have an art group if you're a researcher and you want to talk about your research ideas. We have that. So Kara is going to put some links in the chat so you can take a look at those. Also, just a little plug that we always do an evaluation, very brief, at the end of this to get your feedback. So please don't hop off until you fill out a quick online survey. So I am so pleased to introduce Stacy Stanifer, Dr. Stacy Stanifer, who's an assistant professor in the College of Nursing and the Community Engagement Core lead for UK Cares, and she will introduce our speaker. Thanks, Stacy.
Yeah, thank you, Ellen. Dr. Dresser leads the Climate MD program at the Center for Climate Health and the Global Environment at Harvard T.H. Chan School of Public Health, which works with frontline health clinics to prepare a climate-ready healthcare workforce. He's also the assistant director of the Climate and Human Health Fellowship for Physicians, an emergency medicine physician at Beth Israel Deaconess Medical Center, and an instructor in emergency medicine at Harvard Medical School. Dr. Dresser's current work focuses on the means to address health needs during and after climate-related disasters, and today he'll be sharing this important work with us. Thank you, Dr. Dresser.
Thank you so much for having me, and excited to meet you all. I'm going to spend about 35 or 40 minutes going through a whole lot of slides and a whole lot of material, talking about climate change and how it's affecting our health and what we're trying to do about it. And then I'm really interested to hear from all of you about your perspective on this issue, your experience dealing with these impacts, and perhaps some of the solutions that you are developing or implementing in your clinics or your institutions or your programs. Because I think there's a lot of this that will need to be developed collaboratively in a lot of different situations really rapidly in the next few years. As you can tell, I'm in scrubs. I'm a practicing emergency medicine physician and will actually be going on shift shortly after this talk. And up here in Boston, where I am, we've been seeing a lot of impacts from heat, humidity, and a little bit of wildfire smoke earlier this month. So without more ado, let's talk a little bit of background science. Let's talk about some of the projects we're doing, and then we'll do some questions after that. I do need to mention funding for the projects that will be described in this talk was provided by Biogen and Johnson & Johnson. And then a lot of what you're going to look at in terms of the toolkits and heat alerts and other stuff we're doing is collaborative work between Harvard and AmeriCares and ClimateCentral and the clinics that are actually putting this into action. Big picture, the projects are collaborations that are intended to address needs in primary care or free and charitable clinics that are serving patients who are at particularly high risk of health harms related to climate change or climate responsive hazards, things like heat, hurricanes, flooding, fires. And the idea here is to provide a patient-centric approach to dealing with these problems. I think if you look at the grand scope of climate change and what we're doing about it, there are society level solutions people trying to work on, both from a mitigation and adaptation standpoint. There are institution level, and what we are trying to do here is develop patient and healthcare provider level solutions. I generally start this talk with a quick snapshot of why we need to be thinking about this and how personal this issue can be and is for many of us. This is a patient I took care of during my emergency medicine residency a few years ago that for me was sort of a turning point in my personal engagement with heat and heat-related illness and got me reading a lot about what we could expect in terms of extreme heat in the years to come as a result of climate change. So this was, for me, a watershed moment in understanding and connecting the dots between climate change, health, and my specialty within the House of Medicine. And I think it also illustrates how significant these issues can be to our patients. This is a gentleman who was 45 years old. He was employed. He was working in a parking lot, spreading sealant on a parking lot, that rubber material between the cracks in the pavement. It was very hot. This was a community in New England that is not used to dealing with extremely hot summertime temperatures. And the patient ultimately collapsed, was brought in altered and confused the emergency department where I was working, and we found him to be unresponsive, intubated him, discovered a core body temperature of 108 Fahrenheit or 42 centigrade, and ultimately did rapid cooling using ice water and continuous bladder irrigation with chilled saline, and admitted him to the intensive care unit in single pressor shock, getting additional fluids with a breathing tube in. And if you think about this, this is a person who went to work that day, healthy, alert, and a productive member of society, and spent that night in the intensive care unit on a ventilator. So heat and heat stroke are clearly really significant threats. And as we face a warming planet, we need to be taking steps not only to provide excellent medical care to people who are affected, but to do what we can to prevent this from happening to patients under our care or patients in the communities where we live. Who's at risk? Well, lots of different subgroups of the population, people who are older and live alone, people who are pregnant, people living with various medical conditions or disabilities, people who are children, people who work in hot environments, including outdoor workers. And there's also a substantial geography to this risk. Some parts of cities are hotter than others or hotter than the surrounding countryside. And so we need to be thinking about where our patients live and what our different communities that we serve in healthcare may be experiencing in terms of summertime heat. The second case I want to share is another patient I took care of, also in my emergency medicine residency. And again, that shaped my understanding of how climate change and its impacts are going to cross state lines, and they're going to result in impacts even far away from the location that may be directly affected. This was a patient I took care of, again, in Boston. He came to our emergency department directly from our airport in the fall of 2017. And he spoke Spanish and explained that he had run out of insulin and blood pressure medicine and other medications that he needed. And his daughter had ultimately gotten him onto a flight to Boston, and he came directly to our hospital to establish care, wound up having a variety of metabolic and cardiovascular issues, and wound up admitted to the hospital. And he had not been directly impacted by Hurricane Maria, but he was living the experience of someone who did not have access to consistent medical care after a disaster. And I understand some of the people on this call are working on projects to understand what a post-flood or a post-disaster environment means for cancer patients or other patients that are really dependent on maintaining that close relationship with their healthcare providers and with the pharmacies that provide medications for them. So this is obviously not an environment that you see in this picture that is supportive of good continuity of care. And so a lot of people wound up leaving. And so as a result, many different patients and providers all over the United States wound up caring for Americans from Puerto Rico in the aftermath of that storm. And as we see more climate responsive disasters occurring, we can expect more impacted people, more access to healthcare issues, and more displacement and either short-term or long-term mobility that we need to be ready to deal with. The other thing we need to do is prepare for supply chain issues. Many of you probably who work clinically will remember the normal saline shortage in the aftermath of Hurricane Maria. And this is, I think, a little bit of a bellwether event where we're realizing we need to be able to provide care even if a major disaster occurs in a place that does a lot of our medical manufacturing and is involved in our supply chain. So that's framing a little bit of how I came to this issue and why I see this as extremely relevant to anyone working in healthcare or public health as an important piece of how we understand the world and understand the context of our patients' lives. So how do we connect these dots big picture? This is obviously a complicated and kind of scary problem. How do we get down to some solutions and actions that we can actually take? Well, first, we need to understand what we're dealing with. This is a talk on climate change in which I'm going to spend less than a minute explaining climate change. There's lots of good resources out there that you can read. I'm happy to chat more in the Q&A if anyone has specific questions about this. But in broad summary, we have been burning a lot of fossil fuels for over a century. Carbon dioxide, methane, and other greenhouse gases are building up in the atmosphere. And those greenhouse gases act like the glass in a greenhouse, or as I will sometimes put it, simply an insulating blanket around the planet. The result is rising temperatures. We've already seen a little bit more than a degree centigrade of planetary warming, and we can expect to see quite a bit more in the years to come. How much more? Well, that depends on policy decisions at national and international levels around energy systems, transportation, and how quickly we can move away from using fossil fuels. How does this affect health? Well, as the planet warms, a lot of things are changing. Sea levels are going up. Oceans are getting warmer. Air is getting warmer. Warm air can carry more moisture, and that means potential for more rainfall, more flooding, more severe hurricanes. We're also seeing higher temperatures that translate into heat waves, and in some cases, droughts and increased risk of wildfires. And we're seeing long-term shifts in biomes and ecosystems that are also changing patterns of things like vector-borne disease. So we're seeing health impacts for individual patients. We're also seeing impacts on healthcare systems. If you think about that photograph I showed you of Hurricane Maria, there's obviously a great deal of difficulty in providing care at a healthcare institution in a location impacted like this. And we actually had to change how we did antibiotic infusions in Boston because there was not enough saline to go around. So healthcare systems are being impacted, and finally, society as a whole is being impacted. And that feeds back on people's health in a variety of ways. I'm going to present 3 ways to connect these dots between climate change and health impacts that may make sense to different people on this call in different ways, depending on your background and how you like to think about information. The first one is the connect the dots method. This is a causality map or flowchart of how we connect greenhouse gas emissions with a variety of Earth system changes, and then changes in health hazards, and then health impacts. Each arrow here is supported by peer-reviewed literature. This is a very busy slide. There will be no quiz, but I do mention it because it's important to understand there is a good scientific basis for a lot of the statements we are making around how climate change is affecting health. Another model that will be familiar to anyone who's done emergency management work or disaster medicine work is thinking about this as a risk issue, in which risk is a function of hazard, exposure, and vulnerability divided by the capacity of a society to deal with those impacts. And if we think about what climate change means for this equation, it really means that we're seeing more hazards, they're worse, and we are more exposed to them. How do we deal with that? Well, we can reduce greenhouse gas emissions, which will reduce the hazard, reduce the exposure in some cases. We can also look at social and societal factors that may affect our vulnerability to those hazards. And so there may be a lot of long-term big picture work on how we live in a world that is dealing with climate change to live safely. And finally, there may be things we can do to improve our capacity to deal with impacts when they occur. Things like social connectivity, door knock campaigns during heat waves to check on elders who live alone, things like that. So this is another way of thinking about it. And then finally, for those of you who work in community health or primary care, or like me, went to medical school within the past couple of decades where social determinants of health have been a core piece of the curriculum, the social determinants of health model is a pretty good way to think about what climate change means for patients in the communities we serve. This figure here is pulled from the CDC's model for social determinants of health, or social influencers of health. And I've added a second ring around it here just to acknowledge that in the same way that living in an urban food desert is going to affect your ability to eat nutritious, healthy food, living in a floodplain is going to affect your ability to stay safe during floods. And so there are a lot of different social influencers of health that are being explored unrelated to climate change. And I think increasingly a lot of people are starting to say, well, maybe we should look at the impacts of climate change as another layer of social influencers of health. Where do you live? Is it exposed to climate hazards? Is it an urban heat island? Do you live in an apartment building that has air conditioning? Does your window seal effectively? Can you afford an air filter? All of these are socially mediated factors that will affect whether you do well or not when a climate hazard occurs. So a few different ways to think about it. When we come to the scale of healthcare organizations, I like to put forward this idea of climate readiness, which is a phrase I think a lot of you have probably heard. This is getting talked about at high levels in the federal government, the National Academies of Medicine, and many other organizations. And the idea here is that a climate-ready healthcare system is involved in reducing its own carbon footprint and emissions to minimize how much of part of the problem it is involved in adapting to the impacts of climate change, both in terms of keeping that healthcare institution functional when disasters occur or when hazards occur, but also in terms of addressing the health equity implications of climate change for the patients it serves, which may involve approaches or interventions that are much more oriented toward the community than toward action within the four walls of the institution. I'll also mention the CDC's BRACE framework, which we can talk more about in the Q&A. To bring all of this together to the work we have been doing at Harvard Sea Change in collaboration with AmeriCares and other organizations, there has been quite a bit of work on understanding what's the problem and what do people need. So there was a survey done a little over a year ago that surveyed several hundred clinical staff and administrators in free and charitable clinics and other health centers and frontline health clinics in the AmeriCares network to understand their sort of self-reported level of resilience to climate threats, whether they felt they were being impacted, and a variety of other things. And these are two sort of representative questions from that, essentially showing that some clinics are very resilient and a lot of them are not, but that a large fraction of these settings, people do feel that they are being impacted by, for example, extreme weather, which may be attributable to climate change. And so there's a problem and people are not entirely ready to deal with it at the level of the clinics they work in. And second, we also wanted to understand what type of resources do people need. And what came out of that was this clear indication that people want brief informational sheets. That's the leading piece in that left-hand graph. And I think, we can talk more about different ways to communicate and educate on this topic, but understanding what clinicians and community health workers, et cetera, report as their needs, I think is really important as we think about developing interventions. And then making sure that these, when they are developed, are actually useful and effective. So to orient a little bit to what we've done with this information, we have two sort of big picture interventions that we are working on piloting and analyzing this year. The first is toolkits for clinics. The idea here is that based on that needs assessment survey, people want information sheets that they can access, and they would like help with dealing with climate-related disasters. And so what we've created is information sheets aimed at healthcare providers, which provide a highly detailed, referenced, evidence-based set of guidelines around dealing with heat exposure in a patient with MS, for example. And also, we provide information sheets aimed at patients that provide a step-by-step, here's how to develop a heat action plan or a flooding action plan so that you can stay safe. And then finally, developed toolkits for administrators, recognizing that implementing solutions at the level of a clinic or a healthcare institution serving a frontline population is going to involve a lot of institution level action to keep that facility open and effective and to support the work that the clinicians are doing with their patients. The second intervention is this heat alert program, which we are piloting right now in collaboration with ClimateCentral. The idea here is there's a lot of information out there about the weather. You can get that on your phone, you can get that on TV, you can get push notifications from the National Weather Service saying, hey, it's going to be hot out. And the key is probably to figure out how to operationalize that awareness that it's going to be hot into actual action to keep people safe. And so what we are piloting this summer is an alert that clinical staff can sign up to receive that essentially says, hey, you're looking at dangerous heat in the location you're in starting in the next couple of days. Here are a couple of actions that may be helpful to keep your patients safe, and with links to, for example, that toolkit that was developed. So this is intended to also recognize that risk occurs at different temperatures in different parts of the country at different times of year. Early season heat waves are more dangerous. For a given temperature, say 95 Fahrenheit, that temperature is going to be more dangerous up here in Boston, where we're not used to dealing with really high temperatures, than it will be in the South, where people have more cultural experience with this issue, may be more used to dealing with it, and where a lot of the architectural and design decisions have been built with heat in mind. So These two interventions are being piloted with 19 clinics for the toolkits and I think 12 for the heat alerts all over the country. And we will be doing qualitative research later this year to understand how people use these tools, whether they were useful, and in what ways they feel they can be improved. So that is the plan over the next 6 to 8 months to, complete these implementation pilots, learn from that experience from the people who've actually been using them, and hopefully expand and refine these from there. I'm going to pause there for 1 minute in case anyone wants to drop any key questions on all of that foundational information into the chat. And so feel free to do that while I set up the next chunk of this talk. The other half of this talk is going to be a tour of 4 different hazards: heat, flooding, hurricanes, and fires. These are the 4 hazards that we have selected as focus areas for the toolkits that we are developing. And for each of these, I'm going to just do a quick review of how is this related to climate change and, what is the toolkit that we are trying to develop. And for Ellen's question, have we published the climate readiness survey or pilot intervention? Great question. So we are in the process of writing up actually 2 different papers on 2 different needs assessment surveys that have been performed over the past year. So that's in process. Stay tuned for those publications. And the intervention, so the pilot toolkits are available on the AmeriCares website, and I will actually share a link to those toolkits at the end of this talk. So those are freely available to be downloaded. These are version 1.0. They're getting tested and piloted right now. And if you have feedback or thoughts on those, I'm happy to listen and would love an email saying, hey, here's how you can make these better. Are there any known or suspected genetic markers for heat stress vulnerability? I am not the right person to answer that question. That is a really good question, and I will defer that to others. With that said, I'm going to move forward into heat, and we will briefly talk about these 4 hazards, and then we'll do some Q&A at the end. So when it comes to heat, I tend to start with this image from the US GCRP, such as a federal working group looking at what climate change means for the United States. And I like this image because it is historical data. There's no modeling going on in these bar graphs and these maps. This is simply what happens when you add up temperature records. And what you're seeing is longer heat wave seasons since the 1960s and a larger number of heat waves in most cities around the United States. So I think it's fair to say that we are seeing increasing hazards and increasing hazard exposure, just as I was talking about in that risk equation at the beginning of this talk. How did we get here? How is this an issue? Well, part of the problem is high temperatures, right? And that's where your climate responsive variable is in this chain of causality. However, it is not always dangerous to an individual if it's hot out. If that individual is inside an air-conditioned apartment building the whole time and they never see any heat, they're probably going to be fine, provided the power stays on and the air conditioning keeps working. So there's also this second piece that has to line up to produce health harms, which is some sort of social, architectural, housing, geographic issue, power grid issue, that means people are actually exposed to that heat. And so if you combine high summertime temperatures with a big power outage where everyone's air conditioning fails, that's obviously really dangerous. If you combine high summertime temperatures with an unhoused population, again, a lot of people are going to be exposed to dangerous heat. It is worth mentioning that as we think about this from a big picture level, when it gets hot out, everyone turns on their AC. And the hotter it gets, the more people are going to be running air conditioning more of the time. And so that leads to escalating demand on the power grid. And there is the risk of brownouts or blackouts or other grid failure issues when it gets really hot because of that. And so we need to think about that as a built-in vulnerability of an air conditioning based approach to staying safe during heat, which is why thinking beyond purely air conditioning is probably a good idea. We cannot predict the future perfectly. We can create models. And when you look at different models, it is pretty clear that most of the people who are examining future heat are pretty concerned. This is one of several different models. There are huge differences in what numbers you get in terms of people exposed or potential health impacts And I think it's hard to extrapolate out to a health impact decades from now, because I would hope that we're going to take action to address a lot of those social, cultural, architectural, housing issues to reduce exposure to this hazard. But I think it is safe to say that we are going to see a lot more hot weather in the years to come, and that we will need to be involved in developing solutions to deal with it. What this looks like at the level of individual patients is heat-related illnesses, things like heat stroke, which I described at the beginning of this talk, and also heat exhaustion, but also increases in all-cause mortality, increases in all-cause emergency department presentations, and a variety of subacute things such as impaired cognition, particularly in elders who might have early cognitive decline. And so there's substantial risk to patients for a variety of things, not all of which are regularly captured in the statistics that tend to get published around these events. From a healthcare standpoint, we obviously need facilities to be safe places to go and to receive care, which means the power needs to be on, there needs to be air conditioning. And those facilities also need to be prepared to meet the health needs of this impacted population. And that means being staffed and having space to deal with surges in patient volume, which, if you look at what happened in the Pacific Northwest, for example, can be really significant and can lead to a lot of challenges providing care to everyone who needs it. Returning to that risk model from the beginning of the talk, I just want to emphasize for heat that we can think about solving, or at least addressing this problem, doing our best with this problem at a variety of levels. From a hazard level, well, maybe moving away from fossil fuels will mean we can get to a place where we're emitting less carbon dioxide in the atmosphere, and climate change moves to a different trajectory, and we don't deal with heat waves as severe as they could have been in the years to come. From an exposure standpoint, there are things we can do, particularly in urban areas, to change how much we are exposed to heat, things like white roofs, green space, things of that nature. From a vulnerability standpoint, we can think about, well, it's hot, our hazard has occurred, people are exposed to it. How do we reduce their vulnerability to it? And that can be things like, combining air conditioners with off-grid capable solar panels so that people will still be able to have some cooling. And then finally, from a social capacity to deal with this hazard standpoint, there are other things people can do, right? If your air conditioner fails, maybe there is somewhere else you can go. There's somebody who can provide an opportunity for you to stay cool for a few days until the weather gets safer. So lots of different ways you can attack this problem at different societal scales and through different approaches. The way we're approaching this on our Climate Resilient Clinics project is focusing on patient and provider interactions and actions at the level of individual clinics or other health facilities. And so this is an example of the tip sheets for heat that have been written with the intent of providing an evidence-based detailed resource for providers with step-by-step, here's what you need to think about guides. Patient sheets that are intended for a patient with a medium reading level. We are probably going to be releasing an extra simplified version of this, and we also just released Spanish language versions of these 2 weeks ago. And then finally, information for people who are involved in managing healthcare facilities, particularly frontline clinics. So, on the right here, we have examples of what one of those patient sheets can look like. We can talk more about that at the end. The heat alerts are also being refined. This is actually an earlier version. We have updated the language of this since then. But the idea is that people can receive an alert that has a who might be at risk and what can you do about it as a provider. So being mindful of time here, because I really want to hear from all of you about both your thoughts on this work and also what all of you are doing to address this issue, because I think many of you are working on really good projects. I'll also talk a little bit about flooding and rainfall, which, if we think about Kentucky and Appalachia in general, is one of the huge hazards that really needs to get figured out. Again, looking retrospectively at federal weather station data, we are seeing more extreme rainfall events throughout the eastern half of the United States. And certainly in the sort of Appalachian mountain range, this is a huge issue. I think all of you can teach me a lot about that as well. So we think about mechanisms that we're dealing with here. One of the pieces is there is simply more heat and thus more energy available in the climate system, which can lead to more severe storms with more severe wind damage. A second and really crucial piece is that warmer air is able to carry more moisture. That means there are more water molecules up there in the clouds that are available to contribute to rain, and that can result in flooding. I will also mention that atmospheric rivers are a thing. They are beyond the scope of this talk. It is worth reading about what happened in California last year dealing with atmospheric rivers. And I will also mention that, again, social and geographic factors matter a lot in terms of who is exposed to risks from flooding and how badly harmed they may be. The future, again, is concerning, is impossible to perfectly predict, but all of the serious climate modeling suggests that we are going to see more extreme rainfall and more flooding risk in the eastern half of the United States, including Kentucky and the Appalachian region more generally. So we need to engage with this problem now because it is going to get worse. From a standpoint of how does this affect health? Well, there are the direct impacts, the drownings, the trauma, the cuts that get infected by dirty floodwaters. There's also displacement, right? People lose their homes, they find themselves in shelters, they find themselves moving to stay with friends and family. That in turn can lead to loss of access to healthcare, interruptions in chemotherapy, interruptions in insulin access, and a variety of other things that can have really substantial health impacts. And long term, even if people are able to remain in their homes, if their home's been flooded, they may be dealing with substandard living conditions, mold, etc. And so there's a lot we need to be thinking about in that social determinants of health bucket and that access to care bucket that will be affecting a lot of people that we serve as doctors and nurses and other health professionals. Healthcare facilities are also at risk. Obviously, there can be substantial flood damage to healthcare facilities. I personally work in an emergency department in Boston and another one west of Boston. The one west of Boston saw a big increase in emergency department volume after a nearby hospital flooded in an extreme rainfall event that was well outside the design parameters of its landscaping at its facility. That other hospital remains closed 3 years later, and I'm still taking care of patients that used to get care in their emergency department. I can't see their old medical records. This is not ideal. And so even here in Massachusetts, we are very much seeing impacts from flooding of healthcare facilities, and that is impacting patients' ability to access the healthcare that they are used to accessing. Other things to think about at the healthcare facility level include staffing availability and whether staff can physically get to work or whether staff are able to, obtain childcare during or after one of these disasters. And also longer term issues like whether the supply chain remains functional and financial impacts on the institution as well. So our flood tip sheets are a little bit simpler than the heat ones, but basically are focused on preparedness actions and sort of having a pre-flooding plan so that patients have medication lists that they can evacuate with, that patients understand how to get information about when they might need to leave, and that administrators have plans and checklists in place to do what they can to keep their facility safe and open and able to serve its patients. In the interest of time, I'm going to move very quickly through hurricanes and fire, which are certainly still issues, although hopefully a little bit less so for many of the people on this call, if we're focused on the Appalachian region. Hurricanes, when they are happening in Appalachia, are often coming inland and bringing a whole lot of rain. So many of the hazards are very similar to what we just talked about in the flooding section. It is worth knowing simply that with warming sea surface temperatures, we are seeing more available energy for storm formation, and that the air is warmer, can carry more rain. In a lot, although not all ocean basins, we are seeing a higher proportion of the hurricanes that do occur turn into big, dangerous hurricanes. We're also seeing sea level rise. And so for those of you who may be in coastal areas, increasing risk from storm surge, partly because storms are getting more powerful, and partly because the sea level that we're starting with is rising. Both of those combine to make storm surge increasingly dangerous in the years to come. There are also issues around rapid intensification, which means storms that spin up to a really high level of power in a short period of time, which interferes with our early warning system and ability to evacuate people from harm's way. This is a slide I'm going to skip for convenience, and I think we can share my slides at the end. This is the IPCC's version of what I just said. And very much like flooding, this is an issue partly of direct impacts from things like flooding and wind damage and trauma, but huge impacts as well from access to care problems and displacement. At the facility level, direct impacts are a huge concern. And there's also probably going to be increasingly, even for those of us in places that were not impacted by a hurricane, we may well find ourselves caring for patients who were displaced, such as the patient I described at the beginning of this talk. Again, we have a toolkit focused around this. The example on the right is what a provider tip sheet looks like for developing a hurricane action plan with your patients. And finally, wildfire. This has been in the news a lot this summer with the smoke coming down from Canada. In years past, it's been the news a lot, particularly for wildfires in California and other parts of the Mountain West. There will be increasing risk on the eastern seaboard as well, although it does not look like the risk is as extreme as it is in the subarctic and in the Mountain West, but certainly something we need to be aware of. And when it comes to smoke exposure, certainly a big concern. Wildfires are getting worse. Part of this is climate change, things like wet winters producing lots of fuel, summertime temperatures that are hot, dry conditions, high winds, all of which can make wildfires worse. And it's also worth mentioning that decisions about where people live and how we structure communities and urban development and wildlife-urban interface also affects wildfire risk and the risk of people being exposed to that hazard. And so that combination of fuel, often grown in the winter and then drying out in the summer, with high winds, high temperatures, and in some cases drought, that produces substantial risk from fires. And then the smoke can travel enormous distances across continents and across oceans. It's also worth pointing out for any of you who are in California, you will be probably very familiar with this, that in some cases, electrical systems, power grids have been implicated in starting wildfires. So in some cases, grid operators will turn those off preemptively when fire conditions are high risk. And that has a lot of implications for people who depend on home electricity dependent medical equipment, things like electric beds, electric wheelchairs, people who need to refrigerate their insulin, and on and on and on. So again, planning around that is really important. And we are expecting to see more fire risk in the years to come. Models on this vary, and I will not go into the details of that right now. For those of you who are thinking about this from a health or healthcare standpoint in terms of impacts, there's obviously the direct impacts, things like trauma and burns and, high volume smoke inhalation leading to lung irritation, et cetera. But I think it's also pointing out that there's a lot of displacement and the potential for a lot of housing damage for people who are in areas that are directly impacted by fires. And then there is a long range smoke issue that can affect air quality many, many, many miles away from the location of a fire. And, for images of that, simply look at what happened in Chicago or New York earlier this summer. And it may continue to happen for the rest of this season. Healthcare facilities, much like with hurricanes or floods, face direct threats from damage, but also need to make sure that they're managing their supply chains and are able to continue to provide care, and will likely find themselves caring for displaced populations that may show up without their medication list in hand. And so that may require upstaffing and additional phone calls to reestablish people on their home medications, for example. And again, we have tip sheets around this, for example, for administrators on how do you take steps to prepare your facility for fire season and impacts. So in the interest of time, I think we'll handle some of these last things in the Q&A session. Big picture, we need to be mitigating climate change, reducing how bad it gets by reducing greenhouse gas emissions, getting away from fossil fuels. We need to be adapting to the impacts that are occurring, which is a lot of what I just talked about just now. We need to be doing all of this with a health equity focus, recognizing that some populations, some individuals are disproportionately impacted and should probably be prioritized for our efforts to keep people safe during and after these events. There's a lot we can do at a lot of different levels. I imagine some of you are clinical, some of you are research people, some of you are in policy or institutional management. And I think there's something here for everybody. On the clinical side, we can be talking about this issue with our patients. We can provide counseling. The heat alerts and the toolkits we're developing are intended to support that type of work by people. From an educational standpoint, we can be having conversations like the one we're having today to share information and talk about how we might better respond to this problem. We can also do a lot to get awareness of climate change and climate-related hazards into educational curricula or continuing medical education courses, et cetera. At an institutional level, we need to think about our supply chain. We need to think about what we do before during and after disasters. And we also need to think about avoiding being part of the problem and moving toward a more climate-friendly approach to how we provide healthcare from a sustainability standpoint. And then finally, and this is where I think a lot of the big picture solutions will ultimately need to come from, we need policies that address this problem. And that means both moving away from fossil fuel use and also incentivizing organizations to take steps that will do all of the things on the left side of this screen. It also means investing in critical infrastructure. We cannot run healthcare without a functioning power grid. Our patients are much safer with a functioning power grid, with flood barriers that work, with access to clean water. And so infrastructure is also a huge piece of health adaptation to climate change. So I will just close with the idea as follows. This is happening. It's affecting our health and the health of our patients. There is a lot we can do. And this is worth taking action on, worth preparing for. And I think that we can, through those actions, do a whole lot to change outcomes for a whole lot of people. And so I will pause there. These are some links. We can certainly share the slides afterwards to the toolkits themselves on the AmeriCares website on the left, and then to some of the descriptions of this work in more detail on our website at Harvard Sea Change on the right. So I will pause there and be happy to take any questions.
Thank you, Dr. Dresser. That was a great presentation. I think Ellen posed a question in here about healthcare systems, if you want to take a look at that.
Sure.
Ellen wants to talk.
Yeah, I can also just ask you. It's been my observation in Kentucky anyway, somebody can argue with me. By the way, great presentation, is that it seems like healthcare provider or systems get involved in disaster drills, like, you know, and they either have to, I don't know, by law, but they do it. And you see that like once or twice a year, maybe.
Yep.
But when it comes to more resilient, so a lot of the things you talked about in terms of strategies, heat, flooding and stuff, I don't see them being very proactive. In fact, Stacy can probably talk about that more, because as she's talking to providers, I think people just don't talk about it. I mean, and I guess the bigger picture for me from a policies perspective is do any clinical practice guidelines even talk about climate and assessing and all the things that you're talking about? And are you working, at least maybe with emergency physicians, I don't know, to try to integrate that into your clinical practice guidelines? Because my observation as a practicing nurse years ago is that nothing really happens unless the clinical practice guidelines kind of hold you accountable to do it. So anyway, that's my thought.
Yeah, these are all really good points. So to the point on disaster drills, I think we definitely need disaster drills. I think that's really important. So my answer to that is yes, and. You know, institutions need to be doing what they are doing for institutional disaster preparedness. Absolutely important. I think we need to be adding on to that with a proactive, prevention-oriented approach that focuses on the communities that would be impacted. Which, if you think about what an institution is preparing for, it's often that mass casualty incident or that overwhelmed emergency department, which can absolutely happen during these events. The more that we make communities resilient so that people are safe in their homes, the fewer people will need to come to that emergency department, and the less risk there will be of that mass casualty incident occurring. So I see this as complementary approaches. From a clinical practice guidelines or standards approach, this is an actively evolving area. You know, the toolkits we are developing are intended to help meet that need, but they are not an institutional clinical practice guideline, right? That's coming simply from us. The American Academy of Pediatrics is starting to have some interesting conversations around this. A variety of other specialties are starting to engage with this. And if anybody from any of those fields wants to speak to your experience in your field around this, feel free, but there is increasing interest in getting this into foundational medical curriculum and nursing curriculum, and also getting it into, for example, clinical practice guidelines. That will vary enormously by different specialty.
Yeah, the nursing essentials that came out in 2021, there is a short standard in there about including this sort of climate preparedness and natural disasters into the nursing curriculum, but there's not a whole lot of guidance otherwise. So I think people are fitting it in where they can. And I know we cover that in public health nursing at UK, but I'm not sure how others are. We have a question in the chat too from Craig Wilmhoff. So he asks, are the toolkits geared towards urban locations or are they adaptable to rural as well?
That is a great question and is something I'm really interested in hearing about from people who look at these toolkits. So these are written as a one-size-fits-all for US-based high vulnerability populations. That may need to change, right? Like there may be pieces of this where we identify that we need to create a rural subset or an urban subset. So at present, they are geared towards here's what the existing literature and scientific evidence says around things to be concerned about and interventions that may be helpful, most of which has been tested in different and overlapping populations, not exclusively urban, not exclusively rural, probably some combination of those. One of the things we're interested in figuring out as we pilot these this summer with the 19 clinics we're working with is those clinics, some of them are urban, some of them are rural. What is their experience with this, and do they see this as useful and effective, or does it need to be really tailored to, for example, a reservation environment versus a urban heat island environment, et cetera? And so that's an ongoing area that we are looking into. And if you have thoughts on that when you look at these, I would love to hear.
In regards to Ellen's comment earlier about clinical practice guidelines, I know this isn't a clinical practice guideline, but I know Joint Commission earlier this year, which proposed new requirements to address environmental sustainability. I don't know if you're familiar with that, but it was talking, trying to get healthcare systems, because they're large polluters of our environment, to no longer ignore their contributions to greenhouse gas emissions. So I'm not sure if you know where they stand with that.
Yeah, I mean, there are a number of initiatives on this. The National Academies has a decarbonizing the healthcare system initiative. The Department of Health and Human Services, Office of Climate Change and Health Equity, has a White House climate pledge for healthcare organizations, which the hospital I practice at is part of. I think all of these are good steps forward. I think where full system change is going to happen is from either regulation or incentivization at a national scale. And that has yet to happen in a way that affects everybody. I'll leave it there. In answer to someone in the chat, and then we'll get to you, Holly, something about climate hopelessness, mental health impacts, especially in children. I am linking a Harvard Magazine article on climate anxiety that I think will answer your question better than I can, although I am quoted in that magazine article. Bottom line, a lot of people are seeing this. I am not a primary mental health provider, so I will let others in that article speak to their experiences. Holly. Holly Swanson.
Holly, we can't hear you if you're.
Can you hear me?
A little bit, yes.
Can you hear me now? Okay.
Yes.
So yeah, I'm having trouble with I boogered my computer a little while ago. So my question has to do with medical education training, because one of our challenges is that we already have such a packed curriculum. So how can we better incorporate a lot of these concepts into, I would like to see, as a basic scientist, I'd like to see them incorporated into that first 2 years. So do you have any thoughts on that?
Absolutely. So I was involved in a supporting role in the work to get climate change into the curriculum at Harvard Medical School. So starting with the class that is entering this year, that will be integrated into their preclinical years education. What we did, this was led by Dr. Gaurav Basu and a group of medical students. I helped tangentially with this process a little bit. What we did was work on getting this into existing curriculum rather than trying to carve out separate space for it. So instead of doing a climate change lecture as part of that curriculum, instead we do things like identify an asthma lecture where there could be a brief mention of, hey, air pollution is connected with asthma. air pollution is coming from fossil fuels, and you've got pretty good maps of sort of exposure to fossil fuel related air pollution in relation to asthma, because the epi on that has actually been done pretty well. And so that can be included in like a case-based learning exercise on asthma that simply includes a little bit of that social and climate context. In a global health lecture, this can be included as one of several things that a given nation might be dealing with. And so the basic idea is to integrate it into existing material rather than carve out space for it, because that, I agree, is very challenging to do.
Yeah, similar to the way we do the diversity inclusion. We weave it in as a thread.
Yeah, I think the other advantage of that is it clearly communicates it's just part of what we're doing in medicine now. It's not this separate thing. I see there's a couple more questions in the chat. Medical coding, yes. So I would suggest Googling Stefan Wheat, W-H-E-A-T, and ICD-10s and climate change. He just published a paper on this topic, and I will let him speak for himself through his paper. The bottom line I will say is it is hard to get everyone to do anything in medical coding. If you think about my experience as an emergency doctor, simply getting ER doctors to code in an effective way for billing purposes is still really hard for most organizations. So I think it is going to be challenging to get a climate responsive coding thing to happen. But Stefan has an article on that topic that has delved into this issue a lot more deeply than I have. Also, yeah, checking the weather frequently, teachers involved in this, all serious issues and important to be working on. And policy preparation and infrastructure, I could not agree more. We need to be taking steps to do that. I would also love to hear from anyone on this call who is working in this space on solutions-focused research or interventions, and that wants to share with this group. I think we all have a lot to learn from one another if anybody wants to share some of their experience.
I'm going to turn my camera on and call on some people like Craig and maybe Kelly, because I would love you guys to just talk briefly about the drone project that you were doing with the USA Drone Port to sample the waters, the surface waters in the middle of the lakes and what you've kind of found. Craig, are you able to do that? Are you in the middle of teaching? He's a biology teacher, so, oh, it's summer though.
Yeah, I'm here.
Okay.
Yeah, the drone port and students at my high school, we were able to partner up and sample for surface waters from the rivers and streams feeding into the Three Forks of the Kentucky River down here in Appalachia. And luckily, I was able to do some of the sampling pre-flood last year. And then once I got my equipment back after the flood, because most of it was destroyed, I was able to do post-flood testing as well. In several of the creeks, we noticed drastic changes. A month after the flood, it was drastic still. For instance, in E. coli levels in one of the streams was very high. We also noticed that one of the streams that we had noticed before had high conductivity levels. Conductivity levels were even higher after the flood. So we did notice effects of the flood in the surface waters. And with the drones, we were able to sample one right in front of the high school down here, and the kind of the major forks of the river, a little harder to get to by foot. So we sampled with the drones, and we were able to see that some of those actually had higher E. coli levels as well. So we are seeing kind of effects even in the surface waters. And a lot of that is probably due to infrastructure down here. We don't have the sanitation system set up like, the larger urban areas do.
Mm-hmm. Wow. Thanks for sharing. Kelly.
I just really have more of a general kind of comment thinking about, I was glad to see at the top of several of your slides, the focus on mitigation. You know, we all are talking about becoming more resilient, and that's important, and being prepared, but we have so much to gain by doing mitigation up front. And I even think about things as simple as, you know, of course, reducing fossil fuels, things like that, but making our infrastructure much more resilient. I lived in Chicago in the 90s when several hundred people died in an urban area because the power grid failed during a heat wave. And I'm actually surprised that we haven't seen that right now, you know, more and more like out west and, you know, all throughout the South. But because I think we are going to start to see that. So I just would love to see more efforts, especially in academia in general. And when we start doing study, when we study, how can we focus on the best types of mitigation efforts to really bring down the amount of greenhouse gas in the atmosphere? So
Yeah,
just a general comment.
yeah, couldn't agree more. We need to be doing
Yeah.
both. For sure.
I think we're coming down to the last couple of minutes. If anybody has any remaining questions for Dr. Dresser, feel free to unmute yourself or place them in the chat.
And I will sort of close by saying thank you all for listening, and thank you all for the work you're doing on this. I mean, we need so much work from so many people in so many places from so many perspectives. So, you know, thank you for taking an hour out of your day to think about this and talk about it, and happy to be in chat, and feel free to share the slides with folks after the fact.
Thank you.
You were great. Thank you so much. We have a lot of very interested people who are starting to work on this. So you may hear from us. And thank you for letting us use your slides, because we may take you up on that.
Yes, those are a open resource for people to use. And Ketrel, did you have a comment or question you wanted to make?
Oh, we were running out of time, but I don't know. Can you hear me?
Yeah.
Okay. I just briefly wanted to say, thinking about heat and on a global scale, I just came back from Puerto Rico. I took 7 students there, UK public health, College of Public Health students, and the organization that I partner with, that we went, UK kind of partner with Link 8. Anyway, they're getting funding to get different building materials. So concrete, when you build with concrete, it sort of kind of traps heat. And so when you have, you know, those who don't have air conditioners, wall units or central air, it just kind of can act like an oven at the peak time of peak heat during the day. And so hopefully you can hear me, because I think I'm like dragging anyway. So they're getting different composite materials, and they kind of act like, the bricks kind of act like Legos. And in a short story, long story short, it acts to dissipate heat. So, and sort of, you know, take the heat, absorb the heat into the walls, rather than it sort of being in the indoor atmosphere. And so I think if we sort of think about, you know, attacking greenhouse gases, that's a generational project. But when we, in the meantime, for those that are actually, you know, dealing with this, those lower, economically depressed communities, they need help now. And I think using certain building materials that are conducive and sort of ameliorate or alleviate problems in the immediate term is something to think about as well. All right, that's all I wanted to say.
Yeah, the housing issues are incredibly important. And whether it's a building materials thing or a like microgrids thing or a cooling thing, doing housing effectively can do a huge amount to prevent hazards from translating into health impacts.
Great talk.
All right. Good to meet you all. It's been a pleasure.
Thank you. Thank you so much.